This is again my talk on left atrium, which I presented in Mumbai uh, and Eco India last week. What do we understand by left atrium? I've seen the reports, and this is what, probably I had been also doing a decade back. Just take a dimension of the left atrium and the parasternal long axis view, and that's what it is. That's what contains in the report. Most of the reports of echocardiography which I see in my region, they just make a mention of an AP diameter of left atrium. You think, is that enough? Not really. Many a times, in about, I would say about 20 to 30% of patients in my experience would have, posterior inferior superior dimension increase in the left atrium, not the anteroposterior dimension. So if the other dimension increases, you are going to falsely make a wrong assessment of left atrium, saying that this is normal, but it's possible that inferior superior border are more stretched. So now we should do left atrial volume based on area length method, which again your equipment provides you. You just need to feed in the some data. You need to trace left atrium in two views, apical 4-chamber and a 2-chamber view, and then it gives you a volume once you give the length. You can use a Simpson biplane method. Again, your system would give you just need to trace left atrial border in 4-chamber view and a 2-chamber view. In my experience, usually the 2-chamber view LA is larger than a 4-chamber view. So if you want to do LA size, please include 2-chamber view in a biplane. It's always mandatory. Just don't go by 4-chamber view alone, right? And then it gives you a volume. Another important thing that you must enter height and weight of the patient so that you get per meter square. You have to index its left atrial volume. This is how we recognize it today. Unless you index it, it's kind of a useless piece of information. Before you do that, you must remember that left ventricular axis and left atrial axis are not on the same plane. So you actually have to move the probe slightly medially and superiorly to get the maximum size of the left atrium. You may not focus on the left ventricle, please focus on the left atrium. So the axes may be different. Then the best way is to do a 3D heart model. You can do that. It takes about 14 seconds. That's what our calculation shows. And then you get a very good left ventricle volume index. You must index it by the height and weight of the patient. To calculate the body surface area, and machine would give you the index. So left atrial appendage volume index is 46 against a normal of 34. This is how you calculate the left volume. Uh, and to tell you, left volume index based on a 3D echo has a far better correlation than 2D left atrial volume. And mind you, you see this line, 2D left atrial volumes are slightly less, about 10% less than what you would get in MRI, which is a gold standard. So you would be underestimating LA volume if you do it only on 2D. So this is the same guidelines written by Roberto Lang in 2005 when the normal was this, because we were using 2D. Now the normal is 16 to 34 because 3D is more accurate. This is the same person giving guidelines 10 years after, and 34 is now the cutoff limit for the volume. So if it's more than 34, volume is more than 34 centimeters square per meter square, then it is a dilated left atrium. Why, after all, should I take left atrial volume? Why left atrial dimensions? Where, who needs it? Okay, let me give you a little pretext before you actually throw this entire video into the dustbin. Left atrial size and risk, all cause mortality. You look at this normal diameter, mildly enlarged and severely enlarged left atrium, the survivals are different. Now left atrial volume index on cardiac MRI again gives you same kind of we have a larger the volume index, higher is the severity of mortality. Okay. If you have a clinical data of heart failure, you add systolic, let's say ejection fraction, slightly more information about all cause mortality. You add a diastolic dysfunction also, more information. You add left atrial appendage. It is an independent marker for all cause mortality. That is what is LA, which is important. If you don't believe me, I'm going to show you this meta-analysis. Right. Now, this is the hazard ratio. Let's say if you have a person has a coronary artery disease, hazard ratio is 2.3, 2.3 times likely to have a major cardiovascular events, 2.3, that is 2 times higher. If you have ejection fraction less than 40%, 2.6 times higher chance of having problem. The hazard ratio is 8.8 if LA is enlarged. How many times you've been asked what is the ejection fraction of the patient, sir, by a colleague or a surgeon? And how many times you've been asked that what is the LA volume, sir? Because the mortality, morbidity depends upon LA volume far more than ejection fraction. Now I think you're getting the hint. You must do LA volume in patients when we are doing a 2D echocardiography. At least in patients where you see the LA volume appears dilated, LA appears dilated or enlarged. LA actually goes through a lot of remodeling, and these are the stages of remodeling. First, you have a volume or a pressure overload, causes LA enlargement. A long-standing LA enlargement would produce a lot of fibroblasts and a lot of collagen deposit. So this is the degree of involvement of the LA muscle, class 1 to class 4, where you have a severe collagen deposition. Can I see collagen deposition? No, I can, but I can see it in MRI. But then how do I make an assessment that LA is fibrous on echocardiography? You can. You should do a LA strain. So what are the modalities which are used for LA assessment? Are these transesophageal echo, 3D echo, CT angio, and cardiac MRI. Now, as X-ray chest is low sensitivity, echo is good, transesophageal echo is better, and the added information which I am going to share with my subsequent slides. So beyond LA size, LA strain, which is going to tell you about the fibrosis, the expandability of the left atrium is what is LA strain all about. How do you take an LA strain? Newer equipments or high-end equipments have a kind of automated LA. You just have to take LA focused 4-chamber view, not LV focused 4-chamber view. Then you have to either trace the LA border in case you are doing it manually, and area of the thickness should be small. In case you have a computerized system of doing it, it automatically recognizes borders, and in about 10 seconds odd, it gives you the LA strain. LA strain gives you how LV is expanding. So these are the various phases of LA strain, which I would not go into a greater detail. But the most important is reservoir phase. Reservoir phase is a systolic phase where the leaflets, mitral leaflets are closed because of systole, and that is the time LA is filling by pulmonary vein and attains the maximum size. So this is the reservoir strain, which is the most important in left atrium. So these are the reservoir strain values. 40, this is positive value, this is not a negative value, as LA is expanding during the reservoir strain, and then it should be plus 40. If it is less than that, then LA strain is reduced. What does LA strain reduction indicate? There are direct correlates, and we have direct studies that LA strain reduction indicates left atrial fibrosis proven by cardiac MRI. And LA function and LA this thing are depends upon, if you have a strain values which are reduced, they also tell you the grade of diastolic dysfunction. Left atrial strain is an important predictor for paroxysmal atrial fibrillation. There is a study published this week only in Circulation saying the same statement. And once you have a stroke, which you, let's say in a patient where you make a decision of anticoagulation, you use a Chad-Waz score, and if you add LA strain to Chad-Waz score, the risk assessment for chance of stroke in atrial fibrillation becomes higher. So this adds to the information. We probably in future would use LA strain also add up into the Chad-Waz score to risk stratify the patients. Transesophageal echo, I'll just skip through a couple of slides, is a good modality to look at the left atrial and left atrial appendage, and you can see the left atrial appendage orifice velocities. These are the normal velocities. These are the reduced velocities across the left atrial appendage orifice, and in case the velocities are reduced, that means the velocity blood going inside the left atrial appendage and coming out is slower, which indicates risk of thrombus formation in left atrial appendage. You can see a left atrial appendage on a 3D. You can see tumors in left atrium apart from the size on a transesophageal echo. And the CT scan role, let's say what I talk about CT scan, you in CT scan you can actually make an assessment of the left atrial appendage size. You can pick up a few fistulous openings on the left atrium. These diverticula are common and they have been associated with embolic phenomena. Left atrial appendage on CT scan have been given various morphologies: chicken wing morphology, windsock, cauliflower, cactus. Chicken wing is the commonest kind of shape of the left atrial appendage, and the highest incidence of thrombogenicity is in cauliflower shape of, and these are the shapes of left atrial appendage, and they decide the type. Let's say if you have a cauliflower kind of a shape, that is high likely of a thrombus formation. So you can not only that, you can pick up the wall thickness and other atrial septal abnormalities on a transesophageal or CT. Let's skip and go to a role of a cardiac MRI. That in fact is the gold standard. It gives you assessment of the size, left atrial fibrosis. So these are the two most important things what cardiac MRI gives you on a left atrial appendage, left atrial size, gives you the best modality for left atrial size. It's the gold standard, and you can pick up the masses and differentiate between tumor and the thrombus. Left late gadolinium enhancement is a very important sign of atrial function and fibrosis, and it's an important predictor. Then you can do atrial strain also on cardiac MRI, and we know that cardiac MRI is the gold standard. CT overestimates LA size, transesophageal echo or transthoracic echo underestimates LA size by about 30%. Just a views to show you how you can take an LA volume. You can see the various masses. You can make a differential diagnosis there. You can see other structures like a quadratum. And more important than that, you can see a late gadolinium enhancement in the left atrial wall, which is a sign of LA fibrosis. It is a worse prognostic sign. We can do left atrial enlargement on the X-ray chest, but the sensitivity is very poor. You can have a double density sign, oblique measurement of, in case you have a double density sign, take a measurement from a left bronchus to the edge of the left atrial double density, and if it is more than 7, it is enlarged. You have a widening of the carina. You have a posterior displacement of the left bronchus. These are various signs on X-ray of left atrial enlargement. So guys, I have told you left atrial enlargement has a very important clinical bearing. So please don't ignore that. Start mentioning left atrial volumes instead of size on your echo report. Keep, and second most important thing, yes, subscribe my channel, because once I post any new video, you are going to be automatically notified. So you'll keep in touch. So keep learning. Bye for now.